I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the void in myself and feeling what's missing. Better watch the way you going, better go in the right direction. In the moment you stressing, but you gon' be counting blessings. And I know that for certain. Keep on working, open curtains, haters swerving, cause they ain't ready for your final version. I'm never gonna give up, fall down, I just gotta get up,
You're listening to the Tom Ficklin Show on WNHH-LP 103.5 FM, your home for community radio.
Good morning, everybody. And Harry, thank you again for that intro. And that song, Zach Carlin, I had the pleasure of teaching 2 years at Gateway Community College. And Zach was a student. The course was on corporate communications and public speaking. But Zach, that was Zach's A+ project. So the song, rather than writing a script or giving a speech, he created that song for me, and I've been playing it for the last 3 years. So I owe him big time royalties. But Zach Carlin, kind of check him out, and I just love it because of never give up. That's the theme. Even before COVID, even before Adam and Eve, just get up and do what you have to do and pursue your passion. And actually today we're going to talk with Darcey Cobbs-Lomax. Darcey is the Director of Community Connections and Social Impact for Yolo Haven Health Systems. And her passion, her purpose, her product, if you will, all of us, whether you're in manufacturing or corporate America or nonprofit America, you're producing a product. Your existence is a product. And you want to make sure that the public and your consumers and customers appreciate your product and that your product is not a defective one. So again, Darcey Cobbs-Lomax is here. Darcey, good morning.
Good morning, Tom. Thank you for having me.
And again, she's Director of Community Connections and Social Impact at Yolo Haven Health Systems. Darcey and I, we were just going down memory lane a little bit before we went on air, that I met a relative of hers back in 1973, 1974. And I referenced that. I'm not going to mention his name, but I referenced that we all have connections, whether we're aware of them, whether we keep them current and fertile, or whether we even think that they're important. But I think connections in so many ways, connections, relationships, memories are so important at this stage in time as we try to decide that this universe, Darcey, can stay alive. If we as walking viruses can kind of make sure we don't infect one another to our own collective disappearance. I'm not trying to be overly dramatic, but I really, Darcey, this global pandemic has really affected how I kind of think about things. So I'm looking forward to you for you to give me some inspiration and hope for these next 55 minutes. And if you can't fulfill that obligation, I won't put that total burden on you. Even just talking about what does community impact means, community connections, I think that's so uplifting and stimulating and I think catalyzing also. But Darcey, before we get into your current job, you were also with something called Project Access here in New Haven, and that I think also connects with kind of your life journey. So tell us about Project Access and how you kind of have landed in this current position.
Sure. So good morning again, Tom, and thank you for having me. It's always a joy to be with you in your presence and just to chat. And I'm excited to talk to you today and to your listeners. So my career in healthcare was not one that I ever really set out for. When I went to college, I had a roommate who wanted to be a surgeon, and she knew that at 18, and she's a surgeon today. I didn't really know what I wanted to do, but I knew for sure I wanted to work places that would have a positive impact in people's lives. And so my journey of how I landed in healthcare is kind of not a straight path at all, but my first role in healthcare was with the New York City Health and Hospitals Corporation at a small clinic in the South Bronx, where I was hired as an interpreter at a WIC program, a Women, Infants, and Children's program. I'd never been in a city-run facility before. I had just finished graduate school, so I had an MBA, but I had very little work experience. So as I'm sitting with nutritionists translating for them, I realized many inefficiencies in the clinic where I was, and I decided I want to learn the business of healthcare because something about this scenario here seems very wrong to me. There were long wait times. The facility wasn't a place I would want to bring my own children, and so I just wanted to figure out, like, how do you how did this happen for this poor community? I'm in the South Bronx of mostly immigrants. And so I spent some time there. I went over to Harlem Hospital Center for a little while, and then decided to come back to work in Connecticut, and landed at the health department a short time with Mayor John DeStefano as his director of elderly services, and then over to Yale New Haven. And while at Yale New Haven, I had the opportunity to kind of step away from traditional hospital administration and be the executive director of Project Access. And Project Access is a community-based organization with the mission of increasing access to care and services for uninsured and underinsured residents of the greater New Haven community. So essentially, people who do not have health insurance, but have an urgent specialty care need can be connected to care at no cost with the help of a community health worker or patient navigator. And I spent, as people will say, almost a decade there, but about 8 years I spent at Project Access growing a small nonprofit into what I would describe as a mid-sized nonprofit today, and putting in place lots of infrastructure and programs and and processes for the organization. So today, the organization is led by a new executive director. I have moved officially into a role with Yale New Haven Health System. However, Project Access remains a vital part of our community with regard to access to care. It is thriving under the leadership of Giselle Carlotta McDonald, who I hope you'll have on your show.
Well, actually, she's scheduled for next Friday at 11 o'clock.
Right.
So tune in.
I think you told me that. Good. So I hope your listeners will tune in to hear her and what her vision and the board's vision is for the next 10 years of Project Access, and what the impact will be in the New Haven community.
But just before we go to some specific questions, and we had talked a little bit about what we want to review, and we have 55 minutes or so we don't need to rush. But as you sit here right now, and even in terms of your title is what again?
My title is Director, Community Connections and Social Impact for Yale New Haven Health System.
And as you relate to, in your mind, to your current title, and every title you've had, even going back, as you say, I'm really glad you mentioned the Harlem Hospital, and even working for our former mayor, John DeStefano, who was succeeded by Mayor Tony Harp. What does that tell? I mean, you've been paid. The public should know that I kind of know you a little bit, so I could be a little casual.
Right.
Excuse me, a little casual. And we've been on so many Zoom meetings lately. But in terms of as you compare your journey with where we are in terms of people's health access, do you see still a gap? I mean, you've been paid by the IRS. You've been you're a mother. You've been making money, but other people have not necessarily survived and thrived. Are you optimistic? Are you excited? Are you more committed than ever to kind of making health equity a reality?
I absolutely am. As I think about my journey through healthcare, so Tom asked me before the show how old I was, and he guessed a little higher than I am in age, but I am in my late 40s, and I've spent most of my adult career, so probably about the past 20 years or so, in the space of healthcare or human services in some capacity. I want to say that lots has changed, because it has. So we have the Affordable Care Act today, or Obamacare, as some people refer to it. We've had Medicaid expansion in the state of Connecticut. So some things have changed. However, many things have not. So what we know is insurance doesn't necessarily equal access to care. So you can be insured, but equitable access, or your ability to find a provider that accepts your insurance, continues to remain a difficult space that many people live in. But we have also shifted to addressing social determinants of health, which 20 years ago, or even 15 years ago, maybe even 10, weren't really being discussed the way they are today. And social determinants of health are the things that affect your health outcomes that happen outside of the doctor's office. So the neighborhood you live in, the community in which you live. So is it a safe community? Is it a healthy community? Does your community have access to grocery stores or small corner stores or locally owned stores that sell healthy food and produce that you need to eat? Do your children have access to quality education? Do you have transportation? And if you don't, do you live in a community that's walkable, that you feel safe walking in, or that has access to public transportation to get you where you need to go? So there's lots of those types of things. So housing, food insecurity, transportation. We hear a lot more about that today. And there's lots of people thinking about it and talking about it. How we get to that equity really is a team effort. And some communities do a little better than others, but we've got lots of feet on the ground and lots of interest around those areas right now in New Haven and across the state.
When you mentioned social determinants of health, could you also say could you say economic determinants, political determinants, even psychic determinants of health?
I think you can say all of that. I'm not as well versed in some as I am in others, but it certainly is all of what you mentioned that create how healthy someone is. So the Robert Wood Johnson Foundation defines health equity as the fair and just opportunity to be as healthy as possible, right? So it's fairness, it's what's just, right? So we know that ties in lots of other patterns of injustice, which include racism, which include poverty, which include, as you mentioned, political inequities. So all of that together create a space for how healthy, or I'll say unhealthy, you may be. There's some low-hanging fruit though that health systems, I think, can really tackle or partner with others to tackle. And so that's really where my work in this newer role for me at the health system will focus.
Excellent. So let's jump to this big time title here: Director, Community Connections and Social Impact. And I'm not disparaging at all. I mean, we need power and influence and people at the table, as they say, like never before. But it's an intriguing title to me: Director of Community Connections and Social Impact. And it's, correct me if I'm wrong, but is it a relatively new title in the hospital industry?
Well, it's actually a brand new title for Yale New Haven Health System. I suspect there are other health systems that have similar roles. This new role came about in the latter part of 2019. I interviewed and moved into this space in early 2020. And I had a plan of what I thought I would do. And then we moved into a national pandemic. So most of what I had initially planned has not panned out. However, what I have found is that there's very meaningful and important work to do. And so my role sits kind of squarely between our population health group and our community health improvement group.
So it's just layperson's language of what you've just said. Your patients, just give me layperson's translation for what you've just said.
Right. So in this new role, so the Yale New Haven Health System has a Department of Community Health Improvement that's responsible for the community health needs assessment in partnership with other community partners, and they produce the community health improvement plan. They do one in New Haven, they do them in Bridgeport, anywhere we have a hospital, so Greenwich, Lawrence, and Memorial. So there's a group that's tasked with that. They also do a really nice job of cataloging the work that happens in the community that the hospital is responsible for, in addition to community benefit dollars and how those are tracked and where money from the hospital goes into our communities. So I partner with that group. I also work alongside community and government relations in many ways as well, because they have teams or a staff, rather, I should say, that goes out into the community and partners as well and looks for places and spaces that support from the hospital is needed, and how the hospital can be, as Kyle Ballou says, a good neighbor. And then there is also our population health group, which looks at specific populations of need and looks at how we can address barriers around access to care and health outcomes. So my role is not as neatly defined as others that I've had. I sort of have to be very nimble and kind of move between groups. And in many ways, my work is being, I think, as I heard said recently, we're sort of flying the plane while we're building it. So there's a little bit of that's happening, but I've had some really unique and exciting projects that I've been able to work on over the past, I guess it'll be 11 months. Next month will be a year in my new role. So hopefully we'll get to talk about some of those today as well.
Yes. Yeah. And we'll jump to the projects just in 1 second, and I really appreciate your describing not necessarily the hierarchy, but how organizational dynamics kind of impact satisfaction for the overall public. The overall public. You mentioned 2019 is when this opportunity emerged. Is that correct?
That's correct.
What kind of forces do you think, as you look in retrospect, made that manifest?
I think Yale New Haven Health System is committed to doing the best that we can to improve health outcomes for our patients. And the hospital realizes, as do most academic medical centers and large health systems across the United States, that care happens outside the walls of the hospital. And it might be clinical care that actually happens at home, but it's also, how I see it, community care. Like, how is the community caring for the people that live there? So it's not necessarily clinical, but it's what are the things that we can advocate for, that we can support, even if it's not through actual dollars of a health system. Health systems and hospitals have a loud voice politically or governmentally. And so Yale New Haven has a space that they can occupy in that and to advocate for things that are important for the patients that we see in our health system. So I think it's a little bit of recognizing the role that the health system can play in the community, and then saying, well, where are the gaps? What do we need in order to continue to be a good neighbor, be a better neighbor in our communities? And so I think some of that was the impetus for the role that I have today.
Excellent. And I really appreciate you sharing that, because given this worldwide global pandemic, and I'm really calling it a global war, where the enemy is we are the enemy. But separate from that, in terms of where economics might play in the future, we're going to have to find ways of being creative, innovative, not doing the same thing before. Creativity and innovation is going to be like key, I think, to our survival, and not being locked into traditional service delivery systems, if you will. So I really want to applaud you for being in this space at this particular point in time. Share with people in terms of, you referenced some of the adults. You mentioned Kyle, by the way. Just let's give the proper shout out to Kyle Ballou. She is. You mentioned her name.
Right. So Kyle, I couldn't hear you for a second, Tom.
Kyle Ballou. Let's give a proper shout out to her and her title.
Right. So Kyle Ballou is the Vice President of Community and Government Relations for Yale New Haven Health System.
Excellent. Let's jump to a few products so people to kind of see exactly that you're you're being a productive individual. I know your husband thinks you're productive. I know your children think you're productive. But let's let the communities know that when you leave home, let your family know when you leave home, you're up to some good stuff, some good trouble.
Right. Well, one of the projects that I'll say landed before me, or I became part of a larger team, was earlier this year when we found ourselves in the middle of a national pandemic. Yale New Haven Health System looked at putting up not just drive-up testing sites, but walk-up testing sites. So the first COVID testing sites were drive-up. And those were, I won't say they're easy to get off the ground. I was not part of the logistics of that, but it is a real undertaking to move care outside of, the four walls of our hospitals. We're pretty good at that piece. Care inside, but care outside on the ground, I learned is a tremendous undertaking. So when we decided to put up walk-up sites, here is where the multiple departments come together. So you have community and government relations that knew lots of partners in the community to help us find locations to put those sites. You have Lynn Salzgiver's group. Lynn is the Vice President of Community Health and Equity for Yale New Haven Health System. So you had her group that had a lot of data and could say, we know that in this zip code, the poverty level is this, or we know how many patients have come to us from these zip codes who were COVID positive or who are testing positive. So from there, teams of us went around to different neighborhoods and sites and met with churches and community groups and others to see if we could put up a walk-up testing enterprise at that space. And I learned that you have to have good Wi-Fi and there has to be throughput for cars to get in, and where will the lines go? I mean, there were lots and lots of pieces to lining this up. And so that was a really amazing experience to watch and learn how a community testing site can come together with a community partner. And then the thought crossed my mind that, we are in communities where we can have a positive impact. So I asked Yale New Haven Health System if they would allow me to hire community health workers and could we place them at our walk-up testing sites. And their role would be to do a screening for social determinant of health needs. So things that I've previously mentioned, such as food insecurity, housing, transportation needs. Do they have a primary care provider, utility assistance? So we implemented a screening at all of our walk-up testing sites where if someone screened positive and said, I really need help with this, a community health worker would be tasked with helping them address that need. The other big piece that the community health workers, or as we call them, CHWs, the big piece of their work was also connecting patients with MyChart. MyChart is an app that attaches to your electronic medical record, so you could get your test results as well as communicate with your providers. And at first, I didn't know how much of a need that would be, but that has proven to be the biggest need we have seen in the community, is that people really need a way during a pandemic to reach their medical providers. And so enrollment in MyChart has been really a tremendous undertaking for the community health workers. I believe it's more than 4,000 patients have been connected to their providers through MyChart. And once, as a mom, let's say as myself, if I'm connected, I can now go on and get connected to see my children's record. So the ripple effect of that is really big for us and something we're very excited about. We were able to connect patients with primary care providers if they didn't have them. Also, through the CHW table, we were able to give COVID care kits. So anyone who needed them at the testing site could get masks, gloves, hand sanitizer, and then 2 really nice infographic kind of pages in the bag that talk about how to properly quarantine, how to put your mask on, how to take it off, when you need gloves. The information was all available in English and Spanish. And we also, the community health workers that we hired spoke English, Spanish, French, and Haitian Creole. So we really tried to come up with the languages that we see most frequently in our communities as well.
Boy, those are really, really lucid examples, and because I appreciate them because they illustrate, when we talk about you being the director of community connections and social impact, that's kind of an open-ended title to say the least. But these are really some clear examples of why you're needed. So I think you can stay on it. I think you should stay on the job a few more days if they'll allow you to. You mentioned community health workers. Tell us a little bit more about that, because I believe, correct me if I'm wrong, but you're currently recruiting for additional community health worker staff.
We are. So we are still working at the COVID testing sites, the walk-up sites. We still have community health workers at every walk-up site that we have right now in Bridgeport and New Haven, which testing happens Monday through Friday, so 5 days a week. But now that we've moved into the season or phase of vaccination, we already knew there were populations that might be difficult to reach, right? So I know, Tom, you and I are on a variety of committees and calls and Zoom meetings around vaccine hesitancy. And I heard someone say this last week, and I don't remember who, but they said vaccine hesitancy is not vaccine refusal. Actually, it was Amos Smith from Community Action Agency said, hesitancy is not refusal, and I agree. So at Yale New Haven Health System, we are trying to find ways to reach particular populations, in particular those Black and Brown populations, those that are right now over 75 or soon to be hopefully 65 and over, who can register or get connected to a testing appointment. So we are hiring 10 community health workers whose job it will be is to be out in the community. So they will be at churches, at community centers, at government agencies, any place we can have a space to do two things: promote the vaccine with accurate information, whether it's written or verbal in multiple languages, and anyone who qualifies and needs an appointment, they are able to schedule in Epic, at least in New Haven, at Yale New Haven sites, as well as sites that are operated by Cornell Scott Hill Health Center. And we're hopeful to be able to do the same for Fairhaven. And in any of our other delivery networks, they will be able to schedule appointments for patients or community members at those sites as well.
And is this, go ahead.
No, you go.
Is that a temporary position, or is it something that even after this epidemic subsides, people will still be employed?
So that's a very good question. We don't know exactly when the pandemic will end, right? So, one thing I learned, and I learned this at Project Access, and Giselle, I often would say, I'd say, Giselle, here's my idea, and I would map it out on paper. And Giselle would say, well, that sounds good, but let me tell you how this is really going to go in the community, right? So on paper, we can say, we plan to vaccinate X number of people by this date, as if it's going to really happen that way. And you have to have some sort of projections, because that's how businesses operate, and healthcare is a business. However, what we know from working in the community is that those things often don't match those timelines. So while these positions are what we say in the hospital coterminous with funding, I also have a plan B that I'm putting together as a means to try to keep the community health worker staff employed within the health system. There is no shortage, zero shortage of things and opportunities and projects for community health workers to work on. I get asked very frequently, do you have a community health worker who can help with telehealth readiness for my sickle cell patients to assess readiness to again, my chart? Can somebody actually get on? Do they have the technology? We have issues around sometimes transitions of care and patients who are discharged from the hospital being able to have what they need when they get home. Can a community health worker go out with a nurse or someone to assess and check on those things? We have patients who are frequent ED users who don't have primary care docs. CHWs can be deployed there. So these are all other areas that we're talking about really directly right now within the health system, so that at some point when vaccine kind of winds down, these staff that we hire can hopefully be transitioned into other meaningful work within our health system.
I really appreciate your providing that example, because it seems to me, again, for any organization to thrive and be a community benefit, one has to be nimble and, again, I say innovative and creative and just contemporary. And also, I'm assuming, Darcey, that the community health workers can also give you tangible and realistic feedback about what with the boots on the ground. So say a little bit about that, how important that interaction, that dynamic kind of information transfer is, why that's important.
Absolutely. And I just shared this. I shared this last week at a board meeting at Yale New Haven. Community health workers, those who we intend to hire and who we normally do hire, are individuals who are from the community that we're serving. Sometimes they may not live there today, but similar to myself, I'm from Bridgeport. It's this one city in Connecticut I know my way around backwards and forwards. It still feels like home, but I don't live there today. Right. So our community health workers, we hope to hire from the communities that we're serving, where our hospitals are located. They are someone who is a trusted community member. So they need to know their neighbors. They need to know, the owner of the store on the corner. They need to maybe have had experiences with the school system in their neighborhood, or just experiences in that community. They oftentimes, in the past, individuals we've hired have some sort of shared living experience with the population they're serving. So for example, at Project Access, many of the patients who we worked with were from other countries. They were immigrants. They came here from other countries. A lot of the staff that we were able to hire had that same experience, whether they came here as young children or came here for college or came here at high school age. So I think it's very important who we hire. So it's I'll say sort of exclusive to community in that way. And we get a wide range of applicants of people. And I understand, it's a pandemic and people need to work, but we are really targeted and really laser focused on trying to hire individuals from the community. So not just New Haven, but even specifically, specific zip codes or neighborhoods. So the east end of Bridgeport, the area around, Bridgeport Hospital, or in New Haven, in Dixwell, New Hallville, Fairhaven, places where we see pockets of greatest need. Community health workers, just to finish your question, because I don't think I've answered it all yet.
Take your time.
Community health workers are the ears on the ground, right? So I can go to as many community meetings with you, Tom, with others. I can sit on all sorts of councils and things, but I don't live in New Haven. I don't live in Bridgeport anymore. So I don't know all of what's happening on the ground. And data only tells one story. I get lots of data, right? So data tells a story, but there's nothing better than hearing from someone who says, I spent the past 2 days canvassing this neighborhood. I knocked on doors. I heard from this many residents, and here's what they are telling us. That's a very different story sometimes than what the data will tell us. And so the models that I want to see built at Yale New Haven and across our health system are models that really take into account the community's voice, the patient's voice, so that as we think about how do we best use community health workers on the ground or within our four walls, we make sure we're addressing a need that we see in the data, but how does that match up with the need that we're hearing from the community?
Indeed.
And one last thing I'll share.
No, please take your time. Take your time.
I often shared this when I was at Project Access. I said, the community health worker will always know things about how and why a patient accesses care that the provider will never know. Right. And that's just because they become the trusted kind of family friend, or they already are their person, if you will, in the community. They're the one who's helping them navigate all of those social barriers that we, talked about earlier in the show. And they're a liaison, they're a link. So, sometimes a provider, and I saw this happen at Project Access, we would have patients who were non-English speaking, and the provider would give them all of, brochures and instructions in Spanish in writing. The patient, would come back to Project Access because they don't read in Spanish. They only speak Spanish. They may not read in English either, or they may speak some English. So those nuances, while it is very well intentioned by a provider to give information in a different language, the community health worker is that bridge to say to the doctor, Dr. Jones, your patient, this patient who I'm working with is never going to be able to read those. They don't read in any language. So how can we help? How can we interpret? How can we translate? How can we make sure that this patient gets connected to care with the right support and services? A CHW can always be the reminder that says, interpreter services is needed for every visit with this patient, or I'm going to show up with this patient, or help the patient think through their questions. So they're such an important part of care teams from a clinical perspective, but also outreach teams as well from an outward facing community perspective.
And if someone is listening that would like to apply or know of someone that they want to refer to apply, what's the most efficient way for them to do that?
So the best way is to go to our website, which is ynhh.com. And in the search bar, or there's like a keyword you can type in community or community health worker, and the link should pop up. Perfect.
And Darcey, just before we move on to, because I think you recently made a presentation to I believe the board in terms of, because we've talked about the micro level, but let's talk about the policy level for a second. But your scope of influence, so to speak, it's just not in New Haven or Bridgeport.
That's correct. So my role is a health system role, which means that Yale New Haven Health System has hospitals that go. So we have Greenwich Hospital, Bridgeport Hospital. There is the Milford campus of Bridgeport Hospital, which many might have known as Milford Hospital. And then in New Haven, we have Yale New Haven Hospital, which has our York Street campus, the St. Raphael's campus on Chapel Street. And then in New London, we have Lawrence Memorial. And in Westerly, Rhode Island, some people don't know, we have a small hospital just across the border into Rhode Island. And then there is also Northeast Medical Group, which is part of our health system as well. So my role as a system employee is to try to think about all of that, right? It's a pretty wide span of land across the shoreline. My focus has been largely in Bridgeport and New Haven right now, just based on greatest need. And, you know, in other parts of the state, you have more hospitals. So down in the Greenwich, Stamford area, I'll use my word, the burden isn't necessarily the same for our health system as in New Haven, where we are the only hospital. In Bridgeport, we have, you know, friends at, or a hospital, which is St. Vincent's Medical Center, or hospital, which is now part of Hartford Healthcare. But what I can say in this role that spans the entire shoreline of Connecticut, I found great collaboration during this national pandemic. So an example of that is in Bridgeport, bi-weekly, the health department convenes a meeting of the leadership from the 2 federally qualified health centers, so Optimus in Southwest, Yale New Haven, Hartford Healthcare. And the purpose of that meeting is to look at where are people testing positive, where should our testing sites be, what does the outreach look like? And everybody says, you know, I've got the South End covered, or I've got the East End covered, or we're gonna, you know, put a pop-up at this community entity. So that's been a really, really useful way, one, for me to kind of learn who the players are on the ground, but also just to see healthcare in action, really trying the best that we can during a national pandemic to meet the needs of the community.
And I guess even that phrase, healthcare in action, I guess hopefully people will, that might be at least hopefully just one takeaway. But, you know, what does healthcare in action mean? It's not you're having to get a quick ambulance to the hospital, but on the contrary, it's and you haven't used this term preventative, but it seems to me that that's permeating almost everything you've talked about.
Right, that's correct. You know, it's after the definition that the RWJ, Robert Wood Johnson Foundation, puts together around health equity, they have some sentences after it, and it says it acknowledges that it is difficult to be healthy without access to, you know, a list of things. So, you know, with regard to prevention or being proactive about how to be healthy, you know, that is the job of health systems and communities together, right? Because we just know so much more today than we did, you know, 20 years ago when I started this work. So this is a diagram you may have seen, or I'm pretty sure I first might have seen this through the Connecticut Health Foundation, where it talks about only 20% of what happens in your provider's office affects the clinical outcome, but that 80% is what happens outside those walls, some of which is directly related to healthcare, like how you know, can you take your meds on time? Can you get them on time? Do you have electricity in your house, and you're on, and you have sleep apnea, and you have a CPAP, you know, a lot of those kinds of things. But in America, we don't invest that way. We don't invest 20% in healthcare and 80% in social determinants or the social piece of things. It's really quite the reverse. So we find ourselves sort of in this conundrum of, well, how do we manage this if most of the financial resources go to the clinical outcome, but, you know, only a small piece of them go to the social, you know, the social aspects, the community aspects, the government aspects. I don't have a solution to that. That is not my it's not my area of research or anything, but there's lots of papers and literature about it. But I can say that Yale New Haven Health System is committed through my job, through community government relations, through community health, of thinking about how do we keep our communities healthy, or better yet, how do we get them healthier? And that ties into some work I'm doing around a health equity strategy for our health system. So
tell us a little bit more about that, because it's important for people to know that this is 2021, and unfortunately, or fortunately, people are still so suspect of folks in higher positions. I mean, you are in a relatively high position, you know, in some really significant ways. You're also providing I think a very transparent and important service. But you have interaction with the policymakers at the hospital system. So tell us about some of your recent interactions and what you're proposing and what folks are possibly adopting from a health equity standpoint.
Sure. So I'll start with this. It is my goal that within Yale New Haven Health System that we will talk about equity as much as we talk about safety and quality. We hear the word safety, quality all the time. And we should, because hospitals should be safe. They should be places where you can go to get care and not have, adverse outcomes that are a result of things not being safe. And healthcare quality is absolutely important. But you can't have safety and quality without equity. And so to go back to the definition from the Robert Wood Johnson Foundation, it's a fair and just opportunity to be the healthiest you can be. So when individuals find themselves within our hospital walls, they should know that they're going to get safe care, quality care, and equitable care as well. Meaning that what the process for diagnosis should be fair, should be just, and it should also consider that there are some populations who have historically been marginalized and who continue to be marginalized today that are going to require additional support or additional resources in order to get them to that same outcome as another population. And so that is the messaging that I've been taking around to leadership within Yale New Haven Health System. And as a result, we have convened a health equity steering committee, which started, I believe it was last November, which is comprised of leaders from across the health system. And I wish that I could say, we've got the strategy all figured out, but we don't. But Michael Holmes, who's our chief operating officer, he newly moved into that role. He said to the steering committee, he said, we need to go slowly now so we can go faster later. And from that, what I took was it's really important for us to be very intentional and deliberate about looking at what we're good at as a health system and where the gaps are, and really do the foundational work. And there's some things that we will have to own as a health system that, yes, we do great in this space, but there are some things where we may have dropped the ball or not even realize the ball was in our court at that point, right? And that's a hard space to be, right? People want to be a success, right? And I think that Yale New Haven does do amazing work across the shoreline at all of our hospitals, but some things around equity, I think we can improve on. And so we're in the process of determining what specifically those areas are. So over the next 90 days, and I guess we're probably about 30 days into that 90 days, we're doing some foundational work. We're cataloging our work by community, internal, looking at what we do for employees as well as clinical outcomes. We're looking at how we collect race, ethnicity, and language data. What do we do with that data? Marcella Nunez-Smith is part of this committee. She's been wonderfully helpful with helping us think through that process of data and how we collect that data. We are also looking at some national best practices. So that work is very internal to us. It's being done by employees to just see where we are. And from there, we will develop a system strategy for addressing the gaps that we find. And so part of that,
no, please go ahead.
And so part of that, once we identify those gaps, we'll also be using our community health needs assessment, data from Data Haven, the community health improvement plans. So I've had conversations with Lynn Salzgiver and Nancy Hampson from the community health improvement side to say, how do we use what gaps we find internally to support their work externally? And I know that they're working together to think about what that looks like differently for the community as we enter into the next community health needs assessment and improvement plans in 2022. 2020, yes, next year. So this year, it seems like they'll be gathering the data. The plan will come out, about a year from now. And how do we partner differently with the community for that? And so last week, I had the opportunity to go before the board of directors of Yale New Haven Hospital, so not the system, but the hospital, with Marcella Nunez-Smith and Kevin Myatt, who is our senior vice president of human resources for the health system, to talk about a health equity strategy for the system. It has been very well received, in particular by Dr. Churchwell, who I know you have coming on your show.
Yes, next Monday at 11 o'clock, please tune in.
So he will be on. I've had conversations with him about the importance of health equity and really intentional work around this area and building infrastructure within our system to address health equity needs of our patients. So he has some thoughts on it as well, but he's very much in support of this work coming down the pike from the hospital.
I mean, that must give you a little sense of if not a lot, I don't want to put words in your mouth, a sense of excitement and just inspiration. I reference that because a lot of my shows, Darcey, in the beginning, I would talk about how challenged I am to keep my mental optimism. And I say that because if I talk to anybody and they say they're doing well, I say, well, you may be doing well, but tell me how you're really doing given this circumstance. But just hearing you describe the process, the specific process that's in place, the specific community accountability strategy that's in place, that's inspirational. I think people need not necessarily just the word hope, but just to see that we can, be incrementally productive and even successful in the short and long term in terms of whatever your vision or passion might be. You mentioned Dr. Marcella Nunez-Smith. I'm glad you did. She's been on the show a few times, and I say this to say that in spite of I'm from Pittsburgh, but been here in New Haven since '71. I think it's fair to say that the Yale New Haven hospital system in its various iterations has been, if you do a ranking of hospitals nationwide, we're in the top 10. Is that fair to say?
I think it's fair to say. It depends on which ranking you're looking at, but it is a top academic medical center in our country. Yes.
And we take that for granted. I think we tend to take that for granted. There's clout and influence in this little old state, so let's maximize it for everyone's benefit.
Right.
We have about 15 or so minutes. There was a question about how can one participate in the steering committee. I'm not sure if you referenced a specific.
Nope. So the steering committee right now is an internal steering committee of the hospital. So these are hospital employees who are tasked with doing the work hospitals should do, which is evaluating our processes, our programs, looking at our data, looking at what we do internally right now. So that is not an external facing steering committee. It is comprised of both physicians and non-physicians. So folks like myself, I'm not a clinician. I have no clinical background or training, but there are doctors on this committee as well. And it crosses over into Yale Medicine as well. So Marcella kind of brings that piece in. And so I see a question about community input. So this steering committee is internal facing for now because it's really us evaluating us, meaning so we're looking at, there's things we have to do such as collect race, ethnicity, and language data. Like, what is the process for that? How do we train our staff to collect that? What happens with that data? Who's stewarding that data? What happens in EPIC, which is our electronic medical record? So there's that piece of things. So we're looking at, we have a new vice president of, oh boy, I hope I don't get her title wrong. She's overseeing something called Care Signature, which looks at health outcomes for our patients. So care pathways. So if a patient presents in the emergency department with symptoms of COVID, what is the process and what are all the steps that every patient should get to get a favorable outcome? And how do we look at that through an equity lens? So it's internal in that way. So the work that we're doing right now is not community facing work. There are three pieces to it. So community is one. So we're assessing what we do externally. We are looking at employees in terms of how we train them around diversity and inclusion. What conversations are we having about race within our walls and how racism affects patient outcomes and our own biases. So what training do we have for our staff as well as physicians? And then the clinical outcomes piece as well. For folks, oh, go ahead, Tom.
No, go ahead.
I was going to say for individuals who are interested in being part of groups that can help shape how healthcare is delivered in New Haven, there is the Partnership for a Healthier Greater New Haven, which falls under, is led by Augusta Mueller in New Haven, or it's the Healthier Greater New Haven Partnership. They actually had a meeting this morning, it's going on right now, looking at cultural and linguistic approaches to care. So class standards, there's a training happening today. So there is that, group. And I think it's also important for us to remember that we're the only hospital in New Haven, but in all of our other delivery networks, there are multiple hospitals or at least another hospital. We are through these partnerships, not hoping, but we do work with other community providers. So Fairhaven Community Health Center is tasked with, providing preventative care, supportive, health care. Cornell Scott Hill Health Center in Bridgeport, we have Optimus in Southwest. So we are not the only provider of care, but certainly if hospitalized or inpatient, you live in New Haven, you may come to us, you might go to Griffin, you might go somewhere else for care. But it's important to remember that how care happens, what happens in the community, is not solely the responsibility of the New Haven health system, but certainly of the partnerships that are there to work collaboratively to make sure the communities are as healthy as they can be and that people can access care in the best way possible.
Darcey, you've been so clear and illustrative. I really want to thank you. You have to come on my show again. You can be a co-host in any time. I need you. We hear this term in terms of throughout the nation with various states and various municipalities talking about racism as a public health crisis or a public health issue. How does that resonate with you? Do you think this is a fad? Do you think it's a fashion? Do you think it's George Floyd stimulus? Do you think it's something that will last? How important is this? Because again, many states and municipalities are adopting resolutions and plans in terms of racism as a public health issue. I just wondered how that momentum impacts your vision and your purpose.
Well, so I'm Black. I'm a Black woman. So I understand and experience racism probably perhaps in some of the same ways you have in your lifetime, or I think it may show up differently depending upon when you're born and where you've been. I've lived both in Connecticut and in some very rural places in the southeastern part of our country. And I've seen explicit, overt racism in spaces that I've worked and places I've been, and things that maybe I couldn't truly name maybe 15 years ago as racism. So I know it exists. I believe it exists. And you mentioned many municipalities are adopting racism as a public health crisis or statements around that. So do I think it's a fad? I hope not. It doesn't feel like it right now. It is unfortunate that it took a series of really tragic events and a national pandemic for us to really get to a space as community around that. And one of the things that I've shared with with hospital leadership and others is that there's nothing that the COVID pandemic told me about health disparities that I didn't already know existed, because it's the space I've worked in for so long. And I think for many in the health system as well. But I think what has happened now is a national pandemic has shown the whole city, the whole state, the whole country, these health disparities. So people who don't directly work in public health or healthcare now are aware, like, oh my goodness, this is happening, because it's happening to them, right? It's happening to families. Like, these social determinants of health issues are now concerns for individual families. And so you have that piece of things. And so we're left with, well, what do we do with that? Tied in with, blatant racism, killings of innocent individuals, the harming of Black and Brown people in America, lots of things that happened under our previous president and that administration, all of that rolled together, I think has brought us to a point of really having to name racism as a public health crisis, a public health emergency. So I want to say, I hope it's not a fad. I don't want to see those things continue in order for that to stay, at the top of a list of things we need to address. But I think it's also really important, and the onus is on community to continue to be organized and to organize themselves around this topic, right? So health systems have a role to play in that. But I think around topics like these, it's really important for the community to come together to really lead that discussion with the hospital as a supportive partner, right? Because the way I see it is we should always be trying to answer the needs of the community as best we can, right? Health systems can't answer every need, right? We can't pay for police and fire. We can't pay for this Board of Ed. We can try our best to influence things to keep people healthier. And of course, the clinical care when you're within our health system is important to us as well. And so I like that New Haven has legislation going to the Board of Alders in the next week or so around revitalizing the office of what was called the Affirmative Action But now I think it's going to be called Diversity, Equity, and Inclusion to try to bring that back in the city of New Haven. There's a work group that I'm part of around racism as a public health issue. And I'm hopeful that the Board of Alders will pass that work plan that's been put forward to them.
Excellent. Darcey, we have about three or four minutes. I'm sorry, go ahead.
30 seconds. No, I was reading it says 30 seconds.
three or 4 minutes. And this has just been so delightful to have you share. I want to just kind of conclude with a kind of a theoretical question, but I think it's important to me in terms of leadership. You've referenced working in Manhattan, Bridgeport, working for a mayor in terms of that political.
This is Harry Droz, and you're listening to WNHHLP 103.5 FM, New Haven.
Harry is still letting me know 30 seconds. So leadership, if you had to pull out some key words about effective leadership, what words come to mind?
I think leaders have to be listeners. I am learning. I thought I was a good listener. I am learning in this role how to be a better listener, and listening with intent, and to really hear the voice of people, whether it is community, whether it's your peers, whether it's other people at your same stature or space within your place of employment. So I think leaders have to really be listeners, and leaders have to be doers, and not the other way around, right? I can only do what I know to be where the need is, right? So I can, as I shared the example with Giselle, I would come up with ideas, and she would say, well, from the ground up perspective, it's really going to look differently. So it's, I think, a lot about listening first.
Excellent.
And then doing.
Excellent. Darcey, thank you so much for being there. Stay blessed, stay safe. You will have to come back. We've just touched the surface. You got to come back soon. I appreciate you and appreciate all the work that you're involved with. Okay, everybody. We'll talk to you next. Actually, it's coming Friday. We're going twice a week now, and that's the music. So we're being kicked off. Okay, everybody.
I'm never gonna give up, fall down, I just gotta get up, hey. Yeah, this is my road, lights, camera, action, I'm ready.
You actually got a photo of me smiling.
Wondering what to write about, trying to figure out what it's all about. Excellent